Uh, Thank you, ma'am. Thank you for that introduction. And good evening, everyone. I think, uh, lovely to meet everyone. Without any delay, let's just delve deep into it. I'll just share my screen right now. Is my screen visible?
Yeah,
Okay. Uh, so I think before going ahead, you have been getting trained, and our team, the facilitation team, we work remotely. We are situated across India. I'm the facilitator for the southern region. I'm based out in Chennai, but as I travel as and when required. Similarly, like me, we have facilitators across India who are taking the work that Pallium is doing and collaborating with the local organizations and news centers to take this domain ahead. And maybe we are playing a small yet crucial role in developing these services. So to go ahead with yeah. Yeah. Just for a recap, I think all of you must have by now understood what the palliative care constitutes of and what it is. But just to reiterate, I think palliative care, I believe, is a holistic care which is given to individuals of all age group, where we try to alleviate their serious health-related suffering. And the approach that we take is a totalitarian approach where we cover their psychological, socio-economical, spiritual, as well as their physical needs in this definition. Um, what WHO says is for an effective, I would say, palliative care services to be effective in any region is what they follow through this triangle, that is availability of education, for example, the training programs, the capacity building programs, where the stakeholders are equipped with proper training and given they are provided with capacity building and proper training in this domain where they can render their services to our stakeholders. Then is the availability of drugs, because as you know, the essential narcotic drugs, they play a very crucial role in providing palliative care services. So availability of these drugs is mandatory. Uh, then we need a robust policy, be it on the government and or a non-governmental organization or or a private organization. Availability of a robust palliative care policy is the need of the hour. So this three major part constitutes I would say, the palliative care triangle and the services that goes along with it, which without each other, the triangle just doesn't form. And I think many of the states that we are working with, this is what we are trying to achieve. We are trying to create a triangle where all these three major areas are covered. To get you an Indian context, so palliative care services in India are broadly constituted into three major categories. One being the standalone hospice or palliative care centers, which is quite, I would say, quite abundant in India, or this is what major palliative care services are constitutes of. Second is a department within an hospital, be it a government hospital, be it a private hospital, be it a profitable organization. A department within this hospital is what the second category is. And the third is the community-based home care, um, which I think is quite limited to one state, that being Kerala. But these are the three major categories that we are going to look into, I would say, dwell deep into in the Indian context, right? To give you an idea on standalone hospice, the pics that you see here are of examples of few institutes. That is, one is Parnashraya in Bangalore Hospice. and another is Institute of Palliative Medicine in Calicut. So this organization render their palliative care services exclusively, I would say, where they take care of patients from possibly during their end of life care, or providing them palliative care services from the get-go, where they are diagnosed with any sort of health-related suffering, and parallelly they are given palliative care. And this either might be cancer-specific. For example, Karnashtaya, this is a cancer-specific hospice, and there are other organizations which cover non-cancer too. So second is the department within the hospital. The photos that you see here are in the northeast region, specifically in Mizoram, where the palliative care unit is within the hospital, and these are the hospice units in those hospitals where a team of a doctor, nurses, possibly a counselor, lead these services. Usually, this particular department is associated with anesthesiology or oncology in majority of the hospitals. The photos that you see here are of TCC twins um, in Northeast region. Then comes the community model, where we have where we have two major stakeholders. One primary stakeholder being our patients, and then the microservices where our patients try to get their services. But I think many of these patients, because of the growing distance in the hospital and the lack of availability of services within and in around the patient, many of these patients are left behind. To cover this gap, to build a bridge between the patient and the organization, that is where the MISO model comes in. That is the community model, the model that you see in Kerala. Uh, um, eh, so the healthcare delivery to this, is I would say is rendered through the social capital. The social capital here being our community, because if you see in any community-based model, um, the community is so intricate, I would say, engaged with each other, that everyone is aware about what's happening. So the idea is here to engage the community, which forms a group, and they bridge this gap between the patient and the tertiary care centers. But again, this is one of the most challenging model which can't be replicated easily across India, because um, volunteers play a crucial role in this model, and the availability of volunteer is something, or I would say the definition of volunteerism is something that differs from state to state, from place to place, from districts to district. But we think this is a huge untapped potential which is being left behind, and this is what we are trying to work towards, and this is what we help out organizations with respect to their local context to achieve this community-based model. So as I said, not opting volunteer is something this model cannot sustain with, and they are one of the crucial parts in this model. Just to give you an example of one such volunteers who have been involved with Pallium India for quite some time is Mr. K.M. Nair. He's now more than 70 years old, and he joined army at the age of 17, and he retired in 1992 after a distinguished career. Then in 2002, when his wife was diagnosed with stage 3 cancer, she was brought to Thailand, India to provide the hospice care. And unfortunately, I think she expired in November of 2004. But during that phase, Mr. K.M. Nair equipped himself with the domain of palliative care, and learned about various intricacies involved in this domain. And since then, he has been involved with us in various capacities in providing his help for palliative care domain, be it maybe taking awareness sessions or teaching occupations or counseling them. He plays a crucial role. So this is one such example where volunteers, the sort of services that they can give through volunteering with their nearest organizations or palliative care centers. Um, to give you a detailed insight on how Pallium India works, what is the model with which Pallium India follows, is this chart, is where we demonstrate our model in Trivandrum. That is, we ask our stakeholders to visit to Trivandrum Institute of Palliative Science, and they get a hands-on training program. They study telehealth services, and they get hands-on training experience in our IP unit, OP unit, home care services. Then I think once that demonstration is looked after, the stakeholder is then, I would say, empowered with the training aspect of it, just to make sure the stakeholders, when they return back to their respective locations, they are well equipped and qualified enough to render these services. So to simplify that, we have online training programs, we have on-site training programs also, and some of these programs are quite economical, and I would say um, it's virtual model is something that is quite preferred by our participants because not all of them can travel all the way to Trivandrum, stay there for more than 3 weeks, and I would say get their services. But I think that is where the facilitators come in. Once you complete your training, I would say certification, we help you out to reach out to the nearest palliative care organization where you get your observership, where you learn on the practical aspect of the program. Because in virtual, yes, you go through the theoretical aspect of it, you clear your certification, but without a hands-on experience, you can't render your services. So it's mandatory once you complete your certification virtually, we connect you with the nearby palliative care centers, and then um, after completing your observership program, minimum from 7 days, maximum to 14 to 20 days, suppose that you render your services. Then comes the facilitation part of it. That is the work that our team does. We engage with various government organizations, specifically the National Health Mission, where we help them in implement the National Palliative Care Policy. We collaborate with local partners and new organizations in advocacy and promotions of this domain. We catalyze new palliative care centers, as in we help out organization in setting up new centers, be it a standalone hospice, be it home care services, be it a charitable organization, be it a for-profit organization. We also help out organization in getting them opioids because opioid accessibility is something that is a crucial part in palliative care. And um, we have certain stringent rules state-wise, um, where these NDPS amendments are not followed properly. To give you a brief idea, the NDPS amendments that we call the Narcotic Drugs and Psychotropic Substance Act, which was amended in 2014, it states that any organization that is willing to provide palliative care services should have this RMI that is essential to stop opioids as well as to prescribe it. So be government organizations are deemed RMI, but for private or charitable or for-profit organization needs to get this certificate. Um, then we, as I said, the community model that we talked about, if any of you are in Kerala, you might have visited our link center, right? So we try to get this model to other states in the local context. We collaborate with local partners in creating this community-based engagement model. And each of this division is interdependent on each other. I would say since you see demonstration, then education, then facilitation, without any of this, I think the pyramid just falls. So we are entirely dependent on the various role that different team plays in Pallium India, and that's how we make sure to help out organizations out of our local domain, right? Where Pallium India stands is we provide home care services irrespective of the terrain. These are the link centers that we talk about, that the MISO model, where this acts as a bridge between the macro center and the micro part of it, micro being the patient and macro being the tertiary centers. In these link centers, volunteers are the primary individuals who are the crucial spoke in this circle, and we reach them where they are. Pallium India has around nearly 7 different home care teams that go out on a everyday basis to provide the services through these link centers. And I think that's how the most of the patients feel are comfortable with, instead of moving out of their home, providing care at their comfortable place or at their safe space is what they prefer. And apart from home care services, there are rehabilitation services that are being given to them through our physiotherapy team. And it's not about just medicines. We try to provide food and other activities, be it collecting funds for the needy individuals or the needy family, gathering a community to achieve a common goal. We have our social work and community engagement team. That team specifically works in this domain, where apart from the medical aspect of it, their socio-economical, their spiritual things are taken care of. So that is where our community engagement team comes into play. Our social officers are, I would say, a major primary stakeholders in, where they play a crucial role in connecting, mobilizing the community, taking the message out there, and providing, and I would say, taking this message to the right stakeholders and getting the patients the required help is what they do. And most of the time, I think 90% of the time, we are successful in that. And apart from taking care of the patients, we take care of their family too. We have education programs where the children's of the disease are taken care of through our Kuti Kutam program, right? And then we have our telehealth services, which are available um, on all the working days. And we try to cover almost all the languages, primarily being English, Hindi, Malayalam, and Tamil. And through this helpline is how we reach out to various patients who try to connect to the nearest palliative care centers, because we have a database of directories on our website of centers across India, and these centers are verified by us personally. We try to visit to most of the centers just to make sure the information that we have with us is verified, so that the patient, when they reach to those centers, are not devoid of those services. So telehealth also is part of a crucial um, plays a crucial role in providing the services. Coming back to what our team does is, one of our I would say problem statement is to integrate palliative care into the mainstream healthcare. By that we mean to our general healthcare system, where apart from select few organizations or one select state, the palliative care is yet to take off. So my team does this job to make sure we collaborate with local organizations, we collaborate with doctors and participants like you to make sure we set up new palliative care services and provide all the necessary help that is required to set up a new center, be it a small unit, be it a small OP, be it a proper hospice center. We are there with you on the every step. We are just not limited to collaborating with NGOs or governments. We collaborate with private organizations also. We help out organizations with opioid availability. We collaborate with the drug administration of the respective state if there is any blockers created by the administration or any blockers if I would say by chance arises. We are there to sort of smoothen the process and help out organizations in procuring certain, I would say, administrative licenses. And then comes the uh, I would say the community engagement and volunteer mobilization part that we do across India, right? So just to bring back the point, the models through which we can provide palliative care services is one is the government organization through government services. Next is the charitable care. Third is private or for profit, and fourth would be sustainable, which is part of the private and for profit model. And to give you a brief idea, majority of the palliative care centers in India comes under the charitable care model, and there are very limited for-profit or private organizations that dwell into this domain. And yes, there are quite limited government centers too that provide palliative care, but there are. But the volume of centers that we require, apart from the Kerala state, is something that we are yet to reach out to. I'd like to give you a quite an interesting statistic. We have around nearly 850 verified centers on our website where the regional facilitators have tried to verify these centers by physically going there. And out of this 850 centers, I think nearly uh, uh, 650 to 700 of them are within Kerala, and rest of the remaining centers are across India. And I'm including all the other states, including union territories. So I think our role plays a major role in making sure this number increases. So just to show you what the works that we have done. Here is a regional facilitator, Mr. Ron, where we have facilitated the palliative care board in District Hospital of Namchi District. Then here is a health and wellness center in Imphal West in community health center, where they render palliative care services. This is a photo with Nurse Tanita who has won the Nightingale Award with a team of ASHA workers. This is a charity example of charitable care model. The individual that you see in the photo is Mr. Jabaraj, who is providing uh, I would say basic equipments that is required for the patients. And this particular center is in Tenkasi region, and this one particular center nearly caters to a population of more than 1 lakh people. So, and this center has come up very recently, as early as last year in 2023. Uh, Another one of those example is the Shalom Rehab Center in Nagaland. So the geography is not a limitation to us. The another example or for-profit model. If you might have been in southern part of India, you might have seen this advertisement of Atulya Assisted Living. They are one of our collaborators where we help them out in setting up palliative care centers, be it in the education and capacity building, be it setting up the centers, and be it the intervention in the drug administration aspect of it. We collaborate with them too. Uh, so there are certain standard audit tools that are required to setting up a new centers, and these are not. If you see in the standard audit tool, there are two parts which are divided. Part A being the essentials. I think if um, any of the points are missed, I think this center can't be functional. Hence, all the requirements in this part A are mandatory to initiate a palliative care center. Part B being desirables. So, desirables being mm, provision of bereavement support to the patients for once the patient is passed away. Providing bereavement support to the, I would say, to the family is something sort of which is considered desirable because not all these palliative care centers are equipped enough to lend their resources to work throughout with the single patient, right? And most of the centers being charitable centers, they are not economically empowered enough to render all sort of services. So some of the desirables in Part B are omitted, but we try to work with these organizations in ticking all the boxes. But again, because of some limitations, few things lay behind. We'll be sharing this audit tool with you so that when you take back to your organization, it would give you a brief idea on which are the areas that need improvement in improving your services, or which are the areas that are required to mobilize to initiate a new palliative care center. Um, right. So coming to the challenges part of it, so what we have majorly seen is while working with the private stakeholders, there is a lot of myths around palliative care. It's an unfortunate situation, but even within the medical fraternity, the understanding of palliative care is quite skewed because many feel if the exact definition of palliative care is something that is directly related to cancer. And as we say, it's just not cancer specific. It covers the entire, I would say, umbrella of serious health sufferings. Then, when it comes to for-profit or private organizations, they feel this is not very lucrative business. But I feel, but what we have seen is organizations need to be a bit bold in taking these steps. There are the stakeholders are willing to pay for getting the services. But I think the organizations should invest in themselves. They should advertise it. They should reach out to the audience that they are catering to. That's when the business model or business end of it takes off. And I would say one of the secondary reasons that most of the organizations don't prefer getting involved into this is the procurement of opioids part, because there comes with procurement of opioids, you need to follow quite a few, I would say, stringent steps to make sure there are no misuse of opioids and there are documentations that needs to be maintained. But instead, but due to, I would say, in order to play safe, not many doctors get involved into this because they need to keep a check on everything. And I would say um, one of those being primary reason, then being the limited trained human resources. Then if within a private organization, and then there is a mismatch between the, I would say, the aim of what we are trying to achieve in order to make sure the patient is doing well, the referral process doesn't take place well, because some believe, referring them to the palliative care is something, uh, I would say, is not economically profitable to the organizations. That's when I would say the maybe some of the misunderstanding between the department comes in. Then, even if the organizations which have I would say, working towards this domain, they hesitate to share the good practices. I think that that is where we come in. We try to connect organizations on a large scale basis where they share their practices, where they show how the work is being done in the local context. Yes, our organization is working headquartered in Trivandrum, and we have and doing a wonderful job within that geography. But I think when the India is such a vast country, and with each state, the geography, the problems, the blockages differs. So any such organizations that are successful in cracking this, we try to take their practices and make sure the community in that region or the community in that state are known about these good practices, right? Uh, Apart from the private, I would say, players, there is lack of serious awareness within the general public, within the government officials, apart from the medical fraternity, because they are not just uh, the stakeholders that are involved. Because I would say, as early as me, I was not aware about this particular domain, but when I knew about this domain and the requirement, and I would say when I knew about this domain, and that's when I felt, many of my relatives who could have had really, I would say maybe last few days that they had, where they could have been pain free, due to lack of awareness within among ourselves also, we were sort of unaware about these centers, and um, so we have to inculcate the awareness of this particular concept in the general public itself. That's when the demand increases. That's how the organization works. That's when the organization will work towards it. Then it would have a multiplier effect, prompting organizations to get into this domain. And this just can't be achieved by the medical fraternity or the public. And to get a national level success, we need government officials, we need robust policies which needs to be implemented without any, I would say, um, without any gaps in implementations, right? From the primary healthcare center to the tertiary centers, we should have a robust policy within the government system. That is when the burden doesn't lie on the charitable organizations or private organizations. Um, Again, I don't know how many of you are aware, but we do have a national palliative care policy, and each state should implement this policy. But unfortunately, there are very limited states that have palliative care services included in their government centers, in their health and wellness centers, and as well as the advertisement of these centers, right? For example, the Kerala has its own state palliative care policy. I think Kerala was the one that first brought in their own state palliative care policy, which acted as a reference for the national palliative care policy. In 2019, the state of Tamil Nadu also brought in their state palliative care policy. So once the policy comes in, that's when we can see a large, see a
Have we lost contact with him?
Yes, ma'am. I think he lost his network. Let me connect him.
yeah, the Tamil Nadu state palliative care
Yes,
policy.
state policy
Yeah,
is what you were
yes. Yeah. So even the state of Tamil Nadu has brought in the palliative care policy, which is available in the public platform. So for references, you can download these policies and go through that, which would give you an idea how government is trying, how government is looking at this domain, how they're trying to achieve it in a large scale. Yes, you might not see outright visible examples in the government domain, but slowly and steadily we will be reaching there. And I would say, apart from us, the medical fraternity plays a crucial role. If anyone of you are involved in the government domain, please go through that. Try to reach out to your officials, make them aware about it. We'd be happy to collaborate and work towards that. And another being the NDPS amendments. I think priorly, the Narcotic Drugs and Psychotropic Substance Act had huge hindrances. If any organization wanted to stop opioids and to prescribe, there was involvement of quite a few government offices, be it the excise department, be it the revenue department, be it the drug administration. So you had to go through a huge processes just to get morphine. And we being one of the second largest producers of opioids, but the usage of opioids is less than 0.7% in Indian context. So you see where we stand in this, right? So this is what we're trying to work towards and trying to break this myth uh, with the drug administration, because I think our chairman, Dr. Rajagopal, along with like-minded individuals in the palliative care domain across India, worked day and night towards, along with the, I would say, our parliament to bring in these amendments in 2014. What this amendment says is any organization, that is the private organizations, just need to have a recognized medical institute certificate that is enough to stop and prescribe opioids of any formulation. Yes, that is it. And this is valid for 3 years. Uh, and you can stop once you get this RMI and once you get permission from the drug administration, you can place order directly with the vendor. There is no quota system as such. Once your annual requirement is done, you can restock your opioids after getting permissions from the local drug inspector. So that's how it is. But unfortunately, there are many states where these rules are not being followed because of lack of awareness within the government officials and also the lack of awareness among the medical fraternity, right? So that is what we are trying to gain is that to equip them with these new amendments so that they are not unaware about the policies where they can speak freely one-on-one with the drug administration and where in order to procure opioids and so on. So if at all any of your organizations need help with procure RMI, do reach out to the regional facilitators of that region. We'd be happy to help from, we'll be helping you from applying to submitting it to the drug administration to follow up till getting you the drugs in your hand. We are there with you in every steps, right? Um, so just to show you where we are present, right? I am the facilitator of the southern region. I am situated. I am working out of Chennai. I travel as and when required. Then similarly, we have other facilitators across India. Remaining, I would say five facilitators who cover different regions of India are situated across. So I hope Sangeet do post in the contact details of these facilitators. So if you feel like reaching out to any of the facilitators in the particular region, we would be available, happy to help you in any way possible. So yeah, that's pretty much about it. And thank you for joining. And I'd like to know if there are any feedbacks, if there are any questions, I'd happy to take it. So, thank you.
Thank you, Lalit. Sangeet, if you could post the contact of all facilitators in our WhatsApp group, so
Okay,
that
sure.
would be better for them, because I think people are there from different areas in this batch. Thank you very much, Lalit, for taking us through. And as Lalit has mentioned, see, there are different models. He has also mentioned what are the difficulties, why these problems are there, because it's not a profit model. Okay, but at the same time, that doesn't mean it has to be done only as a charitable model. Okay, that also, and the important thing of integrating it, and Palliative has been able to help not only government, they have helped private setups also. For example, in Mumbai and all, the local facilitator has helped setting up a palliative care team in a private hospital. But wherever you do, it will be the same methodology, basically to train. Even now, we are trying to do some similar things in Tamil Nadu, which I was speaking to the organization day before yesterday. Train your staff, then send them for hands-on, then start a setup, then we will help in procuring, and then keep going, and then we will help you in hand-holding also. So every step we can help, but it has to be done in a methodical way. And another thing is that what's happening in Kerala, yes, will happen in due course. I think what it was 5-10 years ago to what it is now is a big change, because we working in palliative care, we can see the change. And if in some states government is also putting some effort, things happen in in both wings. So feel free to ask, whatever queries you would have, let it be any query. Don't hesitate. Oh, my query is small query. My query is a simple query, silly query. Never mind. We'll try to say it may sound silly, but it may be something very important in everybody's mind. So, any doubts in whatever model he said, like demonstration, educate, and then set up, all those, did you all understand? Anything anybody wants to ask, please ask. And how many of you are already working in a palliative care setup? If you could just type in the chat box. See, we have got 65 participants, so that we will know how many are already working in palliative care setups.
And additionally, maybe just to add on a point, ma'am,
Please go ahead.
It would be, let's say if any of you decide, maybe any of the organization decides to initiate their services and post the training, and we have a core team and they require assistance with stream and to learn how to go about it. Our team, that is a team of a doctor, nurse, if required a medical social worker, would travel to that particular location, stay with them from maybe 7 to 14 days or to a month. Who would stay with them, help the organization in setting up their process. And it's more of like an exchange program where our teams also learn and where we help our organizations in setting up their centers. Right, one of our team has went to West Bengal and they stayed for nearly a month. Then they went to Northeast too, and one of our team went to I would say Kasaragod region where we there for more than 7 days. We helped out organization in streamlining their process. So there is that. So the assistance from
Just one query.
yes.
What is it? When you started off, you said some OC. What team you said? I didn't catch what.
The implementation team, ma'am.
Okay. So what I see.
Yeah.
So when they're willing to start, we'll go help them.
Yeah.
That's what I said. No, in all phases. Just someone has asked a query. Does a patient require to be referred? See, there's no hard and fast. See, if a patient is referred, they'll be referred to a palliative care team. So, Dr. Suma, do you have, if there is a palliative care setup already, see, for example, I'll tell you where I have worked. When I used to work in Adayar Cancer Institute, the palliative pain and palliative care team was there. So we used to get patients like the day they come into the organization. That's a tertiary level center. So it will take 10-15 days for the process of all biopsy, fraction, frozen, all that. Diagnosis itself might take. But the patient may be in agony, in pain, and so many other things. So initially they were not sending until. So we told them, and so we used to get patients even on the day they come into hospital. So that is where integrating. So does a patient require referral? Means if you have a setup, then how will you get the patient? So if you could unmute and ask what exactly was your query. So otherwise, how are they going to know that a palliative care exists, or how can you get the patient? So either someone refers, or like, see, it all depends on what type of organization. If it is a big organization, then you need referral. Or if you're going to start something by your own self, then the patients whom you see, you will be seeing them from palliative care perspective also. So it will be better if you speak and ask what was your query.
Ma'am, what I meant is that certain hospitals, certain institutions, they have a very, I would say, a primitive sort of a palliative care center, where the patient is apparently not getting what they expect to get. So would they be able to seek a higher palliative center away from this particular institution where they are getting their treatment on their own, or should they be referred? Can they just walk into, say, Pallium or any other
Yes, see,
center.
exactly. See, for example, now it makes sense. See, because see, as you said, if it is a very small unit where they don't have facility, then they have to go. For example, for Palliative itself, they will come from by word of mouth. Someone told us these things are being done in Palliative. So I will ask them, how did you know about us, or how did you end up coming? So we, like the patient themselves, come to us also. Someone told me I can get all these services. Like that, they come. Either way is possible. See, ultimately, patient needs to get the best. So, and as you said, some institutions, sorry to say, I'm very carefully putting my words. Many times, they don't, like some specialists don't refer also. That's why I'm very hesitant to speak. I'm not speaking ill about anyone or anything. Still, there is a big deal of myth or non-acceptance, non-integration of palliative care into the mainstream. So again and again, I think you would have all had that diagrammatic representation of palliative care, in which like palliative care and curative care goes hand in hand. Initially, curative care may be having a bigger role, palliative care may be having a smaller role. As the disease or the treatment goes, some patient improves, okay, then curative care goes on, palliative care stays still. Do you all remember that graph? Or do you need me to show that to you? So it has to be a hand in hand. So both go together. So that is why integration is important. Not that the patient should be sent to a palliative care physician when everything is not possible. End of life care only is not. See, they are the big myths. End of life care is only palliative care. Hospice is only palliative care. All that myth should have gone off in all your minds, because you all would have known what is palliative care, no? So no more you are still thinking that palliative care is something which you are still, what to say? I'm just trying to see my presentation if I can have, so that I'll show you that graph in a minute. Can I share my screen, Sangeet?
Sure, ma'am. I had made you co-host.
Okay, thank you then. Can you all see my screen?
Yes, ma'am, it is visible.
Okay, so this is what I was trying to say. See, presentation diagnosis. Okay, when you see this graph, that at the presentation diagnosis, the white part is curative. In this diagram, the white part shown by the arrow is curative, life prolonging. That is the curative part. So the patient is getting radiotherapy, chemotherapy, surgery. Think of all possibilities. Okay, that goes. But you see the yellow part? Yellow part is just giving symptom care, pain relief, vomiting. Whenever so many people have chemo radiotherapy, they have intense pain, because that's all neuropathic pain. So all that, when the curative treatment is going on, also palliative care can go hand in hand. Okay, what happens halfway through? Some reason, if the curative care is all going on well and good, hunky dory, let it go on and on. But if some patient has, okay, take triple negative, no response to any treatment, so does that mean that the patient should only struggle? That's where sometimes, no, this delay in referral and all comes. Whereas if the palliative care and the curative care team work together, so both will be seeing the patient. So when curative care is not working, palliative care kicks in more. So see, the yellow part has increased here. So symptom control, supportive care, all that goes on in full form. In that phase itself, hospice or end of life care also happens. Okay. That is what I wanted to mention. Okay, so it has to happen hand in hand. So in that case, this referral, all these things, no, but everything takes time. But for people to accept, that is why awareness has to be raised, and the medical or medical oncology, surgical oncology, and palliative care. Like you have MDT for all your oncology, no? You have MDTs programs, collectively radiotherapy, chemotherapy, all of you sit together and see for this patient what is the best. In that team, you should have the palliative care person also. Okay, these are the options. If this doesn't work, so then still that patient can get palliative radiotherapy, palliative procedures, plus palliative pain relief, symptom relief, total care also. Okay, that's what I was trying to mention. So that is, if it is done in that way, Dr. Suma, then it will make things. And again, your query was if whatever setup is there is a very preliminary setup, they don't have a psychologist, something like that means, then you can refer to a nearby center where better palliative care is available also. So that also, like as I said, patient should know, we should try level best to deliver the best for the patient. Have I clarified your doubt?
Ma'am, so I just wanted to be sure that we can actually suggest a better place if a patient is not doing so well in a current
Exactly.
palliative setting.
See, that doubt itself should not come. See, I generally say, even if you're a general physician, okay, you try to manage, leave palliative care itself for the time being. You are someone seeing a patient, but that patient has severe cardiology issue, ejection fraction, you got do one echo and you get ejection fraction is 40. Will you not send that patient to the cardiologist? Will you still carry on trying to manage that patient? What will you, but so the same thing only. See, one thing all of you should understand. This is not something, this is as we all say, all of us know, but this is just another specialty. And it has many components. So just to exactly put these things, why are you sending that patient to cardiologist? Because that patient should get the best. Similarly, this patient is stage 4 disease. Everything they've tried, nothing is helping. So now every symptom control, not only that, then you have to think whether the patient is going to be managed at home or is the patient able to go to any hospital for care. No, the patient needs to be managed at home. Then how is the patient going to be managed till their end of life? Will anyone be able? So there, a palliative care team who has more facility will be able to guide them. They may have a home care team who can go. Like Palliative, no, we go and send like special home care teams go to people who are in end of life also. So it all depends. If the palliative care service, see, nowadays I think there are more centers which are having, but again, resource, how many doctors or nurses are there, whether everyone is able to run a home care team on a daily basis, all this varies on their availability of resources. So for Dr. Suma, if you know that there is a better service available, there's nothing wrong in referring to the patient. So that, as I say, no, for us, the center of our focus is patient, and our main aim and goal is that center patient to get the best until their last breath. See, there is something where we'll all have one more session on end of life care. No? There is something called as quality, like the way each one dies. That also is categorized, and each country has a place in the world. So everything like birth, death, life, we say quality of life, quality of life. Quality of life is quality of death also is a part of quality of life. When we give so much importance for every day, we have to give importance until each patient's last breath. Just 1 minute, all of us should start thinking, what is that I would prefer for myself? And that is what I should get for my patient also.
Thank you, ma'am.
No worries. as I say, no, better to get clarified and things. May I know, Suma, where do you practice? And
Ma'am, I'm an OD medicine and radiology postgrad working in Government Dental College, Kannur.
I didn't, was your voice was breaking there. Dental college?
Ma'am, Government Dental College, Kannur.
Kannur. Okay, okay. See, that's what. If you have a setup close by, then you can definitely refer them so that they get the best. Many centers are becoming popular and like they, as Lalit was mentioning, you need a doctor, nurse. Basic is doctor, nurse, social worker. Then the next stage will be getting a clinical psychologist or a psychologist and a physiotherapist. These are base minimum. So then you run outpatient services for some time to know how your workload is going to be. So one person, can they manage? No, like, no, I'm seeing 20, 30 patients in a day. Then slowly increase the workforce. Outpatients to start off first, then you go on with inpatient. So then home care, or you start with home care. That's all. It again, demand supply. What is that your area needs? So that is subject. Anything else anybody wants to ask? And as Lalit has mentioned, we have facilitators. If you see the list, Sangeet, have you shared?
Yes, ma'am. I have shared it in the WhatsApp group.
Okay. I'm just seeing that. So that, see, you have people, see, Kerala, like 2-3 states, so that they are able to help you. You have someone for Kerala, then Tamil Nadu, Karnataka, that is Lalit. And then you have someone for Jammu Kashmir, Delhi, Chhattisgarh. Then for Odisha, we have Sunanda. Chandigarh, you have Dr. Jatin. UP. That only Ronto covers little bit more area because it's all in that region. Okay. Otherwise, 4 to 5 states are covered by each person, so that they are able to give full justice to what they need to do. Because they will be able to help you. See, you had opioid availability. That day also Lalit was there with us. Okay. So for procuring drugs, in that aspect also they will help you. And for implementation, see, it all depends. Every stage you can get in touch with Palliative. Be it like a individual person wants to start. Because on that opioid availability session, Dr. Sunil took you through how individual people also can. Because now in the north also, many people they've been doing palliative care services in under a different banner or something like that. So those type of people, like just 1 or 2 doctors, like doctor and nurse together, they do want to expand. So they are also going ahead and doing, where the team will help them to procure morphine and move forward. Because there are many doctors who are already doing home care. Like part of it, they'll do some days outpatient, some days home care, because they have a nurse working with them. Because see, sometimes the follow-up visits can be done by the nurse. If it is a routine follow-up, it is not a complicated one. So then those things, discriminating and identifying the different type of patients that you'll be seeing, you will have to do, the doctor and nurse together will have to set up it. So that's why. So next thing is having some hands-on is very, very important. So you will have to see how these things are happening. Again, for that also, Sangeet, we'll have to share. There used to be information on like all centers in different states recognized by recognized by Palliative, where doctors can go for their hands-on. Just double check that, Sangeet, and share that also in the same group.
Okay, ma'am.
Yes, ma'am. I think we have hands-on training partners respective for the states. So in
Do you
order
have
to
that,
get
Lalit?
observation program, they
No,
Yeah,
you have
I
those
think we'll share the
details.
list, ma'am.
Just share
Yeah,
them.
yeah, we don't mind.
Ah,
We'll share.
because that is also equally important. See, what I generally say is coming to Pallium, well and good. But I also have to understand all of you are from different places and may be able to get 10 days leave, may not. So some people may be able to get 1 day off every week. Okay, as part of your work or something. So if you find a center close by to you, you can go for that for 10 days. So that is what Lalit will share. Okay, so there are so many options. See, that is why, see, we have to be realistic. See, even in communication, what did we say? Give realistic hope, give realistic assurance. Even now, I'm telling, have realistic aims. Oh, I want to come to Pallium only, but I cannot come. Will that work? So that's why you should know what is possible, aim for that, then achieve it. You want to, everyone wants to go to space. Is it possible for all of us to go to space? That's all, simple. Don't think I'm giving you all straightforward. Always better to be practical and then see. So look at options, what is possible. Okay, so you do 5 days there, but still I want to come to Pallium, I'll come for 2 days. Yes, welcome. So coming to Pallium, either contact Sangeet or any team that can be organized. Okay, but again, 10 days hands-on is a must. In your best interest, no best interest for me there. Okay, you all want to be confident, comfortable, working in palliative care. You have to start because see, nothing is simple and straightforward. But at the same time, if you learn and master it, everything is possible. Okay, so those are the important things we need to be aware of. There are no more questions in the chat box. Anybody?
Yes, madam. Madam,
Go ahead.
Jai Sudha from Chennai, madam. Madam, this basic foundation course with this, can we start giving palliative care in our hospital, which is a teaching hospital where there are anesthetists who are, a few of them are qualified to give this palliative care. I'm a physician, madam. I am an internal medicine.
I didn't catch what medical college or hospital you are from.
Ma'am, I'm from Railway Hospital, madam. Railway Hospital.
Yes, you spoke. Then
yes,
in that case, no, you are trained, and if the anesthetic team has a pain and palliative pain, is there anyone in the anesthetic department who is trained in palliative care?
Ma'am, to be honest, they say pain management, ma'am, but so far they have not done any pain management or palliative care.
So
they have not done.
Ideally, see, they like you had session by Dr. Sunil also telling. See, I am also an anesthetist, but when I started palliative, they said I have to do, and I did it. Okay.
Yes, ma'am.
Wherever you are there, you have to follow the norm. So even though I had been doing pain service for 10 plus years.
Okay, ma'am.
Running a clinic, doing intervention, everything. But they told me, oh, you've done everything, but we won't accept. Fine. See, when all of us are following some rules of the land, we have to follow. So, few options is now you having been trained, you are a physician, right?
Yes, ma'am. Yes, ma'am. Internal medicine.
Internal medicine.
Yes.
So, you're doing post graduation?
No, ma'am. I'm an officer there.
Working
yes,
staff.
ma'am.
That is very good. So what you can do is you can join with the anesthetic team and start a pain and palliative care service. The pain, they can also be with you, and if you can just request them, one of them can do the same online course, and then you, I would say you can, because you're in Chennai, you can go for hands-on in Chennai itself.
Okay, ma'am. Okay.
Adayar is linked. I have worked in Railway Hospital and I have worked in Adayar also. Your Adayar madam is actually trained madam from Railway Hospital. And Adayar Hospital and Railway Hospital are linked. You send all your oncology patients to
yes,
Adayar.
Ma'am.
I have seen all your patients there.
Okay, ma'am. Okay.
I would say do a 5-day or 10-day hands-on. That too, as I'm telling, at your convenience, not in one go. do in
Okay.
some way. And you see, Railway Hospital will be an RMI already. Lalit, all that
Okay.
you can help. Railway Hospital is a recognized teaching, training,
Training.
multi-institution. Okay,
Yes, ma'am.
so
Yes, ma'am.
getting morphine is not a big deal. And
It's
only
available, madam. It is
I know
available with us.
morphine
Yeah.
tablet available.
Yes, ma'am.
Ah,
Injection and tablet both are available, ma'am.
see, we need tablet only initially.
Okay.
If you want to give trial and all, so ideally, dear, find one anesthetist who is interested.
Okay.
Okay, find one anesthetist who is interested, and then you join with them and start OP 1 day in a week.
Okay, ma'am. Okay.
Just start off like that, and when you start that, you go for 10 days hands-on, and then
Okay,
you'll be
ma'am.
a queen in it. That's it. Then get in touch with us anytime.
Yes, ma'am. Honestly, this course has helped me a lot because the way I've started seeing patient with COPD, stroke,
Can you
and
switch on your video if you don't mind,
oh,
so that I can see you?
ma'am, I'm sitting in the car. Is it okay for you?
Never mind.
Because
See,
I'm
I have done my training from Railway Hospital. Okay,
okay, ma'am.
I am a
Okay.
railway employee's daughter.
Oh, good, madam. Good to know that, ma'am.
So your Perambur Railway Hospital, I know in and out. Like that is but 20 years ago. I
Yes,
have.
ma'am.
So just get hold of because the other institute HOD, who's now the director of Cancer Institute.
Sagar, sir.
No. Like Dr. Kalpana Balakrishnan, who is the
Okay.
anesthetic. She is from Railway Hospital.
Okay, ma'am. Okay.
So just get hold of one anesthetist who's interested. Just so
Okay.
that together you can start working.
My husband is an anesthetist in Railway
My
Hospital,
good
and
God, slowly
he
you're
has
telling.
he has taken up this Pallium course, ma'am. He only forced me to do this course.
So then both of you together work there. Start
Okay.
one half a day OP to start off. Okay.
Okay, ma'am. Okay.
Half a day, once a week, you do the hands-on, and together you start, and then feel free to get in touch with us, and we will be willing to help you. And Lalit will help you with procuring or anything. Lalit is in Chennai. I am also
Okay,
basically from Chennai only.
Okay, ma'am. Anything, I'll reach out to you both,
Yes,
ma'am.
yes.
Sure.
Don't hesitate to reach out to me, to
Sure.
Lalit regarding thing, and please start because
Okay.
Railway Hospital has all the resources, and
Yes.
your patients are coming. Because I remember even when I used to see in Adayar, they'll tell, Madam, Railway Hospital prescribe anything, everything they'll get reimbursed.
Yes,
So
ma'am.
step center I will do.
Yes,
So I
ma'am.
see
Okay.
so many patients in
Okay, ma'am.
palliative care in Adayar.
Okay, ma'am. Sure, ma'am.
Going for hands-on to Adayar, no, you have to contact Dr. Meenakshi in Adayar Cancer Institute.
Okay, ma'am. Okay, done, ma'am.
Then when you contact her, tell my name. No worries.
Sure, ma'am.
Okay?
Sure,
Go
ma'am.
there
Yes, ma'am.
for however convenient for you, and
Okay.
do 10 days hands-on. And Adayar has got all type of patients. If
Okay,
you go
ma'am.
for 10 days, you yourself will feel more confident. Please do
Yes,
that
ma'am.
without much delay.
Sure, ma'am. Sure. Okay.
Jai Sudha.
Jai Sudha, ma'am.
You're a physician.
Yes, ma'am. I'm a physician.
Very good,
Yes.
very good. See, that's what we need. See, physicians, anesthetists, not because we see all patients, so managing. Not that everyone can do. There are some MD pathology, MD. They also non-clinical people who have become palliative care physicians.
Yes, ma'am. This
So
field of medicine, ma'am, after I took this class, it's really throwing a lot of light on how we have to manage patients, because it's a tertiary care and people come here. As you said, drugs are free. Anything you name, they will get.
see, as I said, I worked in your pediatric department.
Okay.
I started my DNB there.
Okay, ma'am. Okay.
So
Okay,
I know. I used to see your OP runs 9 to 5. No other place runs an OP from 9 to 5.
Yes, ma'am. Exactly.
So I've done that. 50, 60 patients, inpatients I've seen in the pediatric unit.
Yes, ma'am. Yes, ma'am. Okay,
So,
ma'am. Thank you, ma'am.
no
Thank you.
worries. Please go ahead, and we'll be happy to help you.
Sure, ma'am. Sure. Thank you, ma'am. Thank you.
It will be very nice if it starts there, because slowly what will happen, radiation, the best team who are interested in helping and involving is radiation oncology.
Okay, ma'am. Okay.
So anesthesia, radiation oncology, and yourself. this will be a
Okay.
very good team to start
Team.
with.
Okay, ma'am. Okay. Done, ma'am. Thank you, ma'am.
May God bless you, and
Thank you, ma'am.
please,
Thank you.
please feel free to get in touch.
Sure,
Okay?
ma'am. Sure.
Bye.
Okay, ma'am.
We
Thank
can
you,
help.
ma'am. Yes, ma'am.
Okay, Sangeet, I think I'll hand it over to you. Generally, is anybody else having any queries? Please go ahead. I'm just checking if normally Dr. Sundaram, once oncologist used to be there. He will ask some questions and queries. I think he's not there at all today. I was just checking the participants. That's all. Some Sundaravadanam or someone from Tirunelveli or one oncologist used to be there. I think he's not there today.
Yes, ma'am. He's not there today.
That's all. So I think thank you very much, Lalit, and you can Sangeet. I'll hand it over to you. All of you feel free to get in touch with us if you need anything.
Thank you, ma'am. I hope all your queries have been answered. If you have any queries, you can post it in the WhatsApp group. And if you need any assistance with getting RMA status or setting up palliative care services, you can contact Lalit or any other regional facilitators, which I have shared the details in the WhatsApp group. Then once again, thank you, Lalit, for the wonderful session. Thank you, Radha ma'am, for facilitating the entire sessions. Thank you all for joining today's sessions. Thank you. Let's see you in the next session. Bye.
Thank you, one and all.